morning. My name is Liza Rosenman, and I'm joined by Rose Fernandez from University of Florida. And we're going to discuss today the interface between resuscitation team leadership, gender, and gender bias. We have funding from the Agency for Healthcare Research and Quality, as in the Department of Defense. We have no conflicts of interest to disclose. So why this topic? So people started to ask the question about care delivery based on provider gender. And this was a New York Times coverage of a study in JAMA in 2017 from Tsugawa and colleagues looking at care delivery by gender. And the same question has been asked in resuscitation care as well. And we know that resuscitation care and resuscitation team leadership are critical emergency medicine skills. So conclusions such as this one, that women perform worse CPR, can be detrimental to provider well-being, to female physicians, to the patient-provider relationship, and as the workplace environment in general. So learning objectives today are to better understand the relationship between team leadership and gender. And to do this, we're going to summarize the existing research evaluating this topic, look at the limitations of assessment practices, specifically focusing on the potential for gender bias, and then look at steps to minimize gender bias moving forward. Before moving on, I would like to acknowledge that the work presented here approaches gender as a binary issue, and this is a limitation of the work done thus far. So the first objective is to look at the literature that's already out there, the research that's already been done. And this starts with Amaker and colleagues in 2017. This was a simulation-based study of ACLS in medical students and medical student teams in Switzerland. And they had a primary outcome looking at hands-on time in the first 180 seconds of simulated cardiac arrest. And they showed that all male teams performed better than all female teams. They had a lot of secondary outcomes in which they looked at clinical metrics and also statements from individuals. And they categorized these as either secure or insecure leadership statements. And so one of their secondary outcomes was to comment on the quality of leadership or leadership performance based on these number of secure statements. So what was good about this study is it included both team leadership and clinical performance. However, it has some significant limitations. So it was simulation-based, limiting its generalizability, and it had very junior medical students. But most problematic really is the construct they used for team lead. Even in the most experienced team leaders, senior experienced individuals, seeking input is a desirable leadership behavior, as is knowing your limits and asking for help. So if you take these junior medical students and you essentially penalize them or call it bad leadership when they ask, it's been 2 minutes, I think we should defibrillate, what do you think? And that's considered poor leadership performance. Then we're misrepresenting what good leadership is. But despite these limitations, this group concluded that female rescuers showed inferior CPR performance and inferior female leadership. So this was followed by a study by Meyer and colleagues in 2019 in direct response. As you can imagine, that prior study, there was quite a lot of criticism of it. It is what generated that statement earlier about female providers doing worse CPR, but also generated a lot of criticism and prompted this study, which was a review of over 1,000 inpatient cardiac arrests requiring CPR at 2 hospitals. So their primary outcome was looking at return of spontaneous circulation and survival to discharge. And for patients, based on whether their code was led by a female physician or a male physician. And they showed that for both outcomes, patients who were cared for by a female code leader had better outcomes. They also looked as a secondary outcome at clinical metrics, CPR quality metrics, and showed no difference there. So this was done in actual clinical care with a larger sample size, but was also limited by being retrospective and the team variability that they were not able to account for. Right? They could look at whether the code leader was male or female, but not other factors such as team size or the composition of the teams. And finally, their assessment was limited to clinical metrics. So not only did they not see a difference in CPR quality, They didn't look at leadership, so couldn't comment on or teamwork on a reason why outcomes might have been different. So their conclusion was that female physician leadership is not associated with inferior outcomes. So the last study I want to talk about is our own work, and this was published this year, and we reviewed trauma resuscitations that were recorded, 120 of them, and we looked at both, these were scored for both leadership quality and for clinical care. And so this was again done in actual clinical care, but was done prospectively and included both the leadership and the clinical metrics. This was limited by a relatively small sample size, and similar to the Meyer paper, we could not account for all aspects of team variability. And there's a lot of interdependence between teams and team leaders. We used a Bayesian parameter estimation approach for our analysis, and this allowed us to take into consideration prior published work as well as our own findings. So specifically, we looked at whether our data supported conclusions made by Amaker and colleagues or by Meyer and colleagues. And ultimately, our data did not support any strong gender-based advantage to either team leadership or to patient care. The only thing that we could conclusively say is that a strong male-based advantage to team leadership was rejected. That model was rejected by our data. Otherwise, it was inconclusive. So our conclusion was that our data did not support differences in trauma resuscitation team leadership or in clinical care based on the gender of the team leader. But now just to stop for a second and acknowledge that this question of gender-based differences in care delivery, while interesting, may not be very constructive. These studies, especially studies that show demonstrated difference by gender, are often picked up by the lay press, and they can be both misleading and potentially dangerous. So I think more important than looking for differences by gender, understanding that we're categorizing people too broadly, is to work towards identifying the specific behaviors that are linked to better performance in whatever realm of healthcare we're talking about, and then focus on training and assessing those behaviors in an equitable manner. And now I'm going to turn it over to Dr. Fernandez.
Thank you, Liza. So as Liza said, there's probably not a lot of useful information or useful practice to be gained by deciding or trying to determine which gender is, quote, better. But what we can try and do is to understand how our leadership assessment practices might be contributing to bias, and specifically focusing for this discussion on gender bias, although it probably relates to other types of bias or other groups. We have to be concerned that assuming superiority of a specific leadership style, such as a directive style, could be contributing to bias, as well as metrics that use vague or undefined language. And we are going to go through some of that with these slides. Liza, can you go to the next slide? So leadership style and gender has been like an issue and of interest for decades. Many companies, so large companies such as GM, Ford, Google, test their employees to determine their leadership style, and they use those to make hiring decisions. This is a Lewin's leadership style diagram, and it sort of translates well to what we think about in healthcare. It's not the only one, and there's nothing about it that's magical, but you can see on the left side of your screen that
Rose, you went on mute. Oh.
Yeah, somebody muted me. So you can see on the left side of your screen that there's this concept of an authoritative or autocratic leader. In the middle, there's this idea of a participative or democratic leader. And the laissez-faire leader, which was on the right, is not really something that we think about in healthcare. But we do think about people who are more collaborative versus people who make more definitive decisions. And when you look at social role theory, historically, male traits tend to be correlated or tend to be related to this I'm in charge, autocratic method that's very task-oriented, whereas female roles, again, social theory, not reality all the time, tend to be more focused on this interpersonally oriented mechanism. And so you can imagine that this becomes challenging, because if you don't fit into your box, whether you're male or female, others can sometimes judge you negatively. And so women can be judged negatively if they demonstrate these autocratic behaviors. Likewise, a male who's more participative could be judged as, quote, weaker in their field. Liza, can you go to the next slide? And we've made a lot of progress, but these gender norms are still far from gone. And what's important to know is that it's not only discomfort associated with being forced to adopt a certain leadership style, but it's also this sense that if what you're trying to do doesn't jive with your own personality and beliefs, people tend to then apologize for what they're doing, and it can impact their well-being and their comfort in the clinical setting. And one can imagine that if you are a young physician or a resident who's trying out being a team leader in the early stages, and you're constantly feeling that you have to apologize for your behavior, or you don't feel comfortable with what you're doing, not from a medical situation, but from a social situation, that can have pretty significant impact. Next slide, Liza. So there were 2 studies done, and the details are here, but what I really want to stress are some of the similarities between these 2. They're both qualitative studies. The one on the left was done in emergency medicine teams, or residents, I should say. The one on the right, internal medicine residents. But the goal of both of these was to understand how the leadership role is perceived and implemented in those 2 cohorts. And both studies uncovered this concept. If you look at I know it's hard to say the 3rd item down, but the 3rd item on these lists, both studies uncovered this idea that directive or authoritative presence is more effective. So this concept that being participative was less effective in situations, and there may very well be situations where that's the case, but this was the overwhelming theme, one of the themes that came out of this study. The other thing that I'll point out is the Linden study in emergency medicine showed that actually both men and women felt that females faced more challenges in leadership roles. So there's this acknowledgement that this is a little bit of a hurdle that women have to overcome. And women in the internal medicine cohort described this additional stress that they feel when they have to act outside of what is a gender norm for them. Next slide. Liza, can you flip me? Oh, okay, there we go. So focusing on this idea of leadership style, much like focusing on this idea of gender, gets us in trouble. Because again, gender and leadership style are intertwined. And ultimately, it doesn't improve what we're actually trying to improve, which is leadership skills and leadership behaviors. Next slide. So I'd like to sort of think a little bit about what it is when we're assessing individuals. What should we be thinking about, and what are some of the components that can contribute to this idea of bias? So first so these 4 pieces are kind of big chunks when we think about assessment and when we think about bias. You have the task or the patient, right? So in a simulated case, this can be the same, but in the clinical setting, the patient is a huge variable, and interacting with patients can be different depending upon your gender, and just overall depending upon the difficulty of the situation. The team or the environment, so are you in a team that looks like you, for lack of a better way to say it? So a somewhat unigender team, are there multiple genders? Do you feel comfortable? Do you feel uncomfortable? So the team and the environment can make a big difference. The ones that we're going to focus a lot on are, not a lot in 20 minutes, but some, are the idea of the rater and the metrics used and how that can have some impact. Next slide. So this is, to me, this is just a great study, and something that I had toyed with but never really implemented, and these folks implemented it brilliantly. So this is from Jew and Van Schaik, and they executed a simulated study. And what they did was they standardized and scripted an entire resuscitation. They they scripted every single role within the team, and they varied the gender of the team leader. So exactly the same words, exactly the same situation, but what varied was whether or not the team leader was male or female. They also had this other arm of the study that looked at whether they were nurse practitioners or physicians, but we're going to focus on the gender piece. So they video recorded those, and then they had residents assess their performance. And the residents were primarily gender even there. You see 89 women and 71 men. And the tool that they used was this Ottawa Crisis Resource Management tool. And that's actually used not infrequently within team measurement. And Liza, can you go to the next slide? And so what they found was that women were scored lower than men on two key domains of the measure: leadership and communication. Problem solving, situational awareness, and resource utilization were not. Liza, next slide. And so I'm going to try and pick up my pace a little bit, but this shows you the Ottawa Crisis Resource Management tool. And you can see here that if you look over at the highest scores at number 7, you have to do things like make firm decisions and know and be in control. But the question is, what does in control mean? What if you're quietly in control? Is it more effective to be loud, to have a tall stature? And that's where some of these measures can introduce some bias. Liza, next slide. But in this study, they did do a really great job of controlling for both the team and the task. But there were two main pieces where bias could come into play. Next slide. And Liza, I'll hand it back to you.
Yeah, so what can we do to minimize this, this potential for bias? And these are our kind of fulcrum points. And in clinical care, we can't change the patient or the task. For the team, and for the tasks potentially, you can use simulation to help standardize the team. This takes away, the team and team leader interdependence, makes it difficult to isolate individual performance. You can't do this for every leadership assessment, but for high stake assessments, it may be helpful. But I have to understand that it may not be enough. And that's what we saw with the study by Ju and Van Schaik, is that even standardizing things, there was still this potential for bias. So what else can we do? The next thing would be intervening at the rater. So it's not enough just to say, well, there's female raters. We just saw that with the resident assessors, about more than half of them were women. And this phenomenon still emerged. So implicit bias training could be helpful, right? And something we should be doing anyway. Rater training, so this would be specific to the assessment tool, so that one could take a vague or assessment measure and build out metrics around it that make it so your raters can use it more consistently and equitably. And then rater evaluations over time, ensure that there isn't too much drift and people aren't, biases aren't creeping back in. And the next is the assessment measure. So, going back to this idea that one leadership style is not inherently superior, and that we should not equate style with effectiveness, and that we need to be very cautious if the assessment measure is relying on personality traits or affect management. And really, instead, what we want to do is look for, develop, or modify assessment measures so that we're using specific observable behaviors. And this is just good in assessment practices in general for reliability, but specifically is here and helpful here to minimize bias. And so, just as an example, there are some, like being decisive. That's a really hard one. I can't say I have answers for all of these, but some of these terms we can do better. So if you look at approachable, for example, that could be replaced with seeks input from the team, encourages team members to speak up. Or maintaining global perspective could be replaced with positions self to see patient, team, and monitor, does not engage in procedures, things that people can look at and agree on. So the take-home points of today is that the research on team leader, gender, and resuscitation, leadership, and care is inconclusive and probably isn't the question we should be asking, right? Anybody can be an effective resuscitation team leader. It's about the behaviors that we're training and the behaviors we're assessing. Leadership assessments that we're using are often influenced by gender bias, and we need to be aware of that and really start focusing on the behaviors, not on style or personality traits. And that's it. And we're happy to take questions, although I think we're right at our time.
Yeah. There was a question in the chat. It was, what if some of these not productive behaviors are more prevalent in one gender? Shouldn't we understand these differences so that at least we could provide a gender targeted education for residents or advocate for increased diversity in the workforce?
So I would argue that if there's non-helpful behaviors or detrimental behaviors, we should be training for the good behaviors and away from bad behaviors. And we should be focusing on inclusivity and diversity in the workforce regardless. So I guess to me, knowing that there's these gender-based differences doesn't necessarily help and might even feed the problem because it's categorizing people pretty broadly when we know that not all males take a directive autocratic approach and not all females take a collaborative approach. And so I think there is some danger in doing that, and we can still focus on the good behaviors regardless of gender.
Do you have any recommendations to help raters eliminate implicit bias? This is a difficult task.
Do you want me to take that? Go ahead, Liza. No, you go ahead.
It's not that I have a specific training. I think these conversations, I think talking about it, and in raters, like getting together, if you have a diverse group of raters, that you can sit down and review performance together and talk about your interpretation of a tool together. If you sat down with multiple people and watched the same person as in the team leader and say, did they maintain control? You're going to get way more perspectives than I think that we realize. And we just assume that what we look at and say that's good leadership, that everyone agrees, and that's not true. So I think it's just more discussion. I mean, there are implicit bias trainings out there, and I think those are probably beneficial and would encourage those. But I think beyond that is discussions around the specific tool and using the more granular tools as well, because they don't allow as much room for bias in the first place.
So I'm going to close with oh, there's one more message. Hang on. Oh, lots of thank yous. I'm going to close with a couple of thoughts on this. We recently published a paper on collaboration and decision-making on trauma teams. I put the reference in the chat, and it was interesting. The findings were sort of the same, where male and female leadership, there wasn't much of a difference that we noticed. However, I think I just want to say, I don't think it's worthless to study gender or detrimental to study gender. I think there's no one leadership style that works in whatever given situation. Sometimes you have to be directive and authoritative in a situation, and sometimes you have to be more collaborative. And so I think there is a lot of work that needs to be done, and gender is one of those biases, just like race, just like other social things, where if you study it, you might be able to solve problems that are bigger than any one study can test for. So thank you all. We are out of time. And I would, if there are no other comments, then we can close the meeting. Do you guys want to say anything further?
No.
Great presentation, really great presentation.
Thank you.